A good morning to each of you. I hope that this Monday is treating you as well as it can. Today is October 2nd, 2023, and thank you for that. Good morning. And we are into our third of 4 sessions on Aging with Grace for the fall 2023 season. We, of course, had our first 2 sessions in September. Today's session, Aging with Grace, Understanding Living Options, is what we're going to get into in just a moment. And then next week, our final of the 4 Aging with Grace sessions, which will focus on paying for aging, will be our topic. For those who I have not yet had a chance to meet, my name is Seth Stander. I am the Community Aging Specialist for HHCI CARES, which is part of the Hope and Healing Center and Institute. CARES is an acronym that stands for Caregiving, Aging, Resilience, Ethics, and Spirituality. And our program is directed by Dr. Peggy Dettermeyer. Each of these sessions is being recorded, and the recordings and the slides will be made available to all registrants after the series is complete. HHCI CARES has a mission to serve our growing aging population and the growing population of caregivers who attend to them. In addition to community education, Dr. Dettermeyer and I focus on consulting with special emphases on hopes and challenges of aging, on bioethics, hopes and challenges of caregiving, and navigating the journey of grief. The Hope and Healing Center is a nonprofit located here in Houston on the campus of St. Martin's Episcopal Church. It is dedicated to meeting the psychosocial and emotional needs of the entire community. And thanks to some very generous underwriting and an incredibly robust philanthropic department, we are grateful to offer our programming to you free of charge. So let's go ahead and get started with today's slides. Living options can become more complicated, of course, as we age, especially if physical or mental challenges may arise. The question becomes at that point, what do we do to maximize our quality of life? Some of the better known options when it comes to living arrangements are going to be covered today. There are also other subjects we won't cover today, such as safe and effective relocation, downsizing, and so forth. We encourage you to go to our website, hhci.org, and to click on the Resources tab. Some of you may have visited there already and clicked on the Events tab in order to, for example, register for this program. It's under the Resources tab that our video library is stored in reverse chronological order. You'll go ahead and wade into those waters to find programs on relocation, on downsizing, and so forth. And I think that the information there is just as valuable as when it was first recorded. As you can see from this slide, what we're going to cover today, in brief, of course, any one of these we can spend the entire hour focusing on and then some. But as a survey, if you will, we're going to cover aging in place, which for most people means at home, independent living, a supplement to living arrangements, adult daycare, home care, home health care, again as supplements to living arrangements, assisted living facilities, nursing facilities, and understanding memory care facilities, memory care units within larger facilities, and finally, a word or two on personal care homes. Now, if we were to poll, I would say roughly 3/4 or higher, could be as high as 80% of folks prefer, when it's a healthy, safe option, of course, to remain in their own homes when it comes to quality and quantity of days. The major considerations for this, of course, are: is it healthy to do so? Is it safe to do so? Now, let's talk for a minute about health. We're not just talking about a person's ability to go ahead and to handle their daily regimen, which we're going to get into in just a moment. We're also talking about having a safe place for people to turn to for socialization, for timely care, for emergency care. So it's not just about being in one's personal space that perhaps you've resided in for decades, and perhaps you are the surviving spouse in a couple. It's about whether or not you know your neighbors, you have friends in the community, perhaps fellow members of the faith communities that you have been affiliated with over the years, who you remain close with and remain in contact with because you are aging in place. If this is happening, of course, it makes sense for you to do everything possible to safely remain in your home. If it isn't happening, in other words, if you're experiencing chronic isolation and lack of socialization as a result, then communal living may be considered as an option, not as much for your physical needs, but perhaps for your emotional, your psychosocial, and your spiritual needs. So these are some things to keep in mind. Having said all of that, it's important to go ahead and to establish some general guidelines in terms of what constitutes physical health and physical safety. So here is a list. It's actually more comprehensive than the government's list of what are referred to as activities of daily living, or ADLs. But these are all of the things that you can do safely and while promoting good physical health in your home: dressing, bathing, meal preparation, eating, ambulating, transferring. And when I say transferring, I'm talking about a safe transfer from bed to chair or walker or cane, or simply your own 2 feet without assistance, or transferring from bathroom, either toileting or shower or bath itself. Toileting is, of course, something here as well: hygiene, navigating stairs. And then the last part, safety and emergency responses. Are you still able to effectively, for example, evacuate should a fire alarm goes off? Should you find the need to leave in a hurry? Are you able to do so in a way that protects your physical health? These are what I consider a comprehensive language of defining activities of daily living. And I'll repeat it in the presentation. And of course, you'll have reference to this later on as well. Let's get to the next slide. There we go. So how do we address the problem of living? I've deliberately left this slide there, not only to go ahead and to go, what's the problem with living? Living is a good thing, right? The question is, of course, addressing the problem of quality of life, not just quantity of life. We're glad that by being here live or listening to or watching this recording at your leisure, or a little of both, depending on your circumstances, you are going ahead and taking on this problem of living head on. We make sure to maximize quality of life, not just quantity of life. Thinking ahead and exploring your options, researching, determining the best fit. This is not a time to be keeping up with the Joneses, so to speak, for those who understand the phrasing. In other words, competing or feeling that there is a sense of competing with your peer group about, having the best a quality of life arrangement. At this point, we're beyond competition. We're strictly focusing, I hope, on what is best for you or your loved one's individual situation. And wherever the right setting happens to be, understanding that you've researched your best options, and to continue this list, you've discussed it with important people in your life, starting with family members, and ultimately you have figured out how to successfully implement whatever plan you have, regardless of the location you choose as a place not only to live out your days, but we want to go beyond mere existence, don't we? We want to go ahead and also have as high a quality of days. And as I mentioned before, that takes into consideration emotional, psychosocial, and spiritual quality of life, not just physical quality of life. So let's talk about this umbrella that is referred to as independent living options. It's going to sound somewhat similar as we go through the next few slides in terms of senior apartments, senior/retirement communities, retirement homes, active senior communities. What will vary are the amenities, the size and scope of what is available to you, not only in terms of living, but also in terms of what the community you've moved into offers you as a participant. One thing that these will all have in common is that they are going to be more expensive, likely, than living at home, unless living at home means bringing in a flotilla of people to take care of those activities of daily living that I referred to. You should, in an independent living setting, not have that concern. So the question becomes, at this point, is my life in my home, in terms of quality of life, not just quantity of days, going to be better than moving into a semi-communal type of environment? The range of costs, as you can imagine, is going to vary widely by those size and amenities. But one thing that's going to be in common is that everyone is functioning at an independent, at a high level in terms of physical and cognitive daily achievement of activities. Example, of course, is moving into a senior apartment. That may be a reason for you to look at the relocation and downsizing videos that we have on our site. Generally, these are geared for residents 55 and up. Again, they're independent, they're self-reliant, and because of their independence and self-reliance, such residents don't need much by way of services other than some minor transportation assistance, some minor housekeeping assistance. Trash pickup is universal. These apartments can start at $1,200 a month and above. They vary widely in price, just like there is a world of difference between a studio apartment and a 4-bedroom multi-story apartment. What, for those who are living on a fixed income, these senior apartments also may offer is subsidy, a low or a sliding scale rent, perhaps even the possibility of vouchers depending on your income level. And this is where, for those who are not yet already aware, or if you've only heard the name once, it's important to remember that every county and territory in the United States has what is called an Area Agency on Aging, a AAA, or if you prefer, the other AAA. This AAA is not annual dues to the American Automobile Association. It is a government agency that is funded by our tax dollars, and it's one of three core agencies that many people don't realize exist until the need arises. The Area Agency on Aging works very closely also with your county or territory's Aging and Disability Resource Center, or ADRC. And if you are looking at long-term care, the long-term care ombudsman program for your county or territory. Now, all of these can be reached through your county's AAA. So on the resources slide at the end of this presentation, you'll have the contact information for Harris County's Area Agency on Aging. Obviously, you'll want to look at your own county or territory's AAA to go ahead and to get introduced to what they offer directly, what their Aging and Disability Resource Center offers, and how their long-term care ombuds program operates. But what they all have in common is that your tax dollars have already paid for them. Now, independent living settings aren't going to be covered by, say, the long-term care ombudsman program. But if you need subsidy because you are living independently enough so that you don't need much or any help with your activities of daily living, and you have aged into a point where you can take full advantage of whatever type of lower sliding scale subsidies exist, the AAA may be able to help you with that. Similar are senior living / retirement communities. Think of this as a more robust model of the senior apartment complex. You're still going to have private apartments. They're still going to vary in price based on size of apartment, amenities of the community, just as I've mentioned the extremes of, multi-level 3-bedroom apartments versus a studio apartment. They're still going to have some type of kitchen facilities, only now you may be looking above and beyond the basic amenities I mentioned before, like periodic transportation assistance, periodic housekeeping assistance, and so forth. You're going to start seeing more structured social, physical, and intellectual activities on site, as well as more robust access to those in your community. You're also going to start seeing perhaps a little bit of meal planning, depending on what you've bought into. Now, when it comes to rental assistance programs, housing choice vouchers, government-owned public housing, and so forth, the level of amenities is going to be different than what you see in a top-of-the-line, pay-as-you-go, thousands upon thousands of dollars a month for your service. I will say that the average, before subsidies kick in, before vouchers kick in, and so forth, if you were strictly paying out of pocket, the average is around $27.50 per month, because again, you're adding on other staff to go ahead and to provide quality of life care if you choose to take advantage of it. And you're also talking about the amenities that you would expect to have for a comfortable communal, or at least semi-communal existence. Now, let's say, despite the best of intentions, you find yourself in need of additional sets of hands. It could be because short-term you're recovering from an elective procedure or you've had a fall and you're in the process of successfully completing your rehabilitation, which perhaps you started at a different location before returning to either your home, your senior apartment, your senior living or retirement community, and so forth. It's important to understand the difference between home care and home health care. Let's talk about home health care first, although I encourage you to look at the slides that are listed here. Home health care provides clinical medical supervision. If you have been prescribed home health care, your Medicare or your private insurance is going to be covering the costs. So ultimately, you want to be working hand in hand with your physician if there are any rehabilitation or wound care or medication needs, etc., that a home health care service and the various skilled providers within that service can bring to wherever you live for a limited period of time, to go ahead and to get you back to baseline after you've had a scheduled or an unscheduled medical event. That's home health care in a nutshell for the purposes of today's conversation. Again, the whole piece, financially speaking, is covered by your Medicare or your private insurance benefits so long as it is prescribed. Now, unfortunately, home care can't be prescribed. It's not considered a medical service, although some of your activities of daily living can be taken care of. They're not considered medical care. In other words, a home care aide is not going to go ahead and help you with, say, your medications or wound care or rehab, but they might help you with, as you have finished a home health care regimen, going ahead and getting yourself up, transferred, bathed, dressed, having meals prepared, making sure that your housekeeping and transportation needs are taken care of. And I will say that ultimately, you have a choice as far as whether you go by word of mouth and choose to hire directly a home aid worker. And the average on that is $15+ an hour direct. Or if you choose to go through a home care agency, since home care agencies are for profit, unfortunately, we can't give you any recommendations as far as what home care agencies we would suggest. Turnover rates are so high that even if we had vetted home care agencies, we can never truly understand as a snapshot in time how well staffed they are. Having said that, in theory, going through an agency and paying a premium for doing so, roughly $23+ an hour at this point. Yes, that is more than $15+ an hour for going ahead and hiring your own home aide. But if that home aide can't be with you for whatever reason, and you are left struggling versus the assigned home aide through an agency who can't be with you, and someone else who they have vetted and trained will come instead, you got to ask yourself which option you would prefer. You are always going ahead and having to balance ultimately what your risk tolerance is. Will I go with someone who word of mouth is superb, relatively reasonable in terms of my budget, but who might not be 100% available, versus an agency that should have a rotation of people available, but I'm going to pay more as a result, and I'm going to need to pay careful attention as to how they staff and train. All of this is going to require some vigilance as well as some faith. I realize holding those two truths up simultaneously can also be a little emotionally challenging, but we're talking about, again, quality of life in all its forms, not just quantity of days. What I will say ultimately is that if you need helping hands, it's far better to get them than to worry about the aftermath physically, emotionally, let alone financially, of trying to do something on your own when you're not quite ready and then suffering an injury as a result. Now, let's talk for a moment about adult daycare. I mentioned is a supplement to whatever your residential setting may be. We're not generally talking about, though, the senior apartment, senior community, independent living kind of settings in which adult daycare is simultaneously used. We're primarily talking about someone who is aging in place and reaching a point where it makes sense for them to have, not just for the sake of socialization, but also for the sake of safety, an opportunity to be in a supervised environment with peers. We're primarily talking about adult daycare that addresses the daily needs and improves the quality of life of those who are living with early to mid-stage forms of dementia. Alzheimer's is the most popular example, but dementia exists in an umbrella of different types and categories. And again, go back to our archive under the resources tab of hhci.org, and you'll see some essential programming on understanding differing types of dementia. Ultimately, the more days you go, and on average, it's about $75+ a day, you'll probably end up paying a little bit lower than that, depending on where you live, if you sign up for more days a week. And remember, when we talk about quality of days, now we're beginning to get into not just quality of days for the adult who benefits from the daycare services, but also any caregiver, and it's usually a family caregiver at this stage of early to moderate stage dementia, where respite for a few hours is so valuable. Again, this is primarily for when you are, as long as possible, aging in place. It doesn't necessarily mean, again, based on the cognitive decline you're experiencing, that you're going to be living alone. It's possible that a loved one is moving in with you, and plans are being made to eventually move to some form of long-term care in which regular supervision 24/7, when it becomes necessary, should it become necessary, is appropriately handled. So let's talk about the 24/7 facilities. And we'll start with the umbrella category of licensed assisted living facilities. We're talking here about locations of 4 beds or above. We'll talk more about the personal care home model in just a few slides, but starting with a home-like model all the way to part of a campus that could be the assisted living portion of what is referred to as a continuing care retirement facility, or a CCRC for short, where you've got folks there who are living in independent living and doing their own thing in the community, as well as partaking of the myriad of activities taking place on their campus. And you're also having the option for those who've bought in for a lifetime residency on those campuses, for those who reach the point where living in the assisted living facility or the memory care or the nursing facility part of that campus proves beneficial, or at least necessary, and hopefully beneficial, of course. We are talking about the activities of daily living again. And when you reach a point where you need assistance with at least some of these. The minimum is two. Um, as far as the activities of daily living, and having your physician ultimately prescribe that you enter an assisted living facility if that is you and your family's choice to maximize your quality of care as well as your quantity of days. Um, Keep in mind again of what we're talking about with that, with ADLs, activities of daily living: the dressing, the bathing, the meal preparation, the eating, the ambulating, the transferring, the toileting, all aspects of hygiene. If there are stairs, safely navigating those stairs. And then, of course, a response to emergencies. Ultimately, these facilities, which may require entrance fees and deposits, are going to go ahead and provide assistance for whatever those activities of daily living may be that you or your loved one now needs extra sets of hands to complete appropriately, safely, completely. There are limits in assisted living facilities based on the resident's physical needs. For example, if you or your loved one has reached the point where you cannot assist in your transfer, say from bed to wheelchair, or from wheelchair to toilet, or to tub or shower, at that point, you're probably looking at a higher level or nursing facility level care, because assisted living facilities are only licensed to go ahead and to do one person transfers. Now, no, that doesn't mean that if an additional staff member is needed, that they will refrain from doing so from time to time. But if it is a consistent need, then ultimately an assisted living facility cannot be your regular home. Now, you might choose out of pocket to hire a 24/7 nurse to go ahead, or an aide, if you will, to go ahead and to assist the staff at the assisted living facility in successfully transferring you in the ways that I've described and more. The cost of doing so, and you'll need to work that out, may be equal to the cost of moving into a nursing facility. And if you have an emotional or psychosocial or spiritual concern about moving out of an assisted living facility where your needs on all of those existential levels are being met, but you need an extra consistent, in this case, outside paid help in order to make sure that transfer is successfully done, most assisted living facilities are going to work with you on this. But it is probably the case that you're going to be looking at moving into a nursing facility at some point once that need proves chronic. I will say that for those who remain mobile, you're going to have transportation to social activities, to shopping, to appointments. And we begin to get into the stage where memory care, whether the assisted living facility is entirely devoted to memory care, and therefore is a secure memory care building, versus a unit which is secured within a larger assisted living facility, where you begin to go ahead and to see memory care options arise. Here's the bad news. As you can see on this screen, rent and meals start on average at about $4,000 a month. And additional fees are usually going to be added in on top of those entrance fees and deposits, because inevitably there are going to be other needs that you will discover along the way, which the facility will be more than happy to cover for a cost. Medicare and Medicaid don't cover long-term care in assisted living facilities. Medicare, for that matter, doesn't cover long-term care, period. Aid will only cover nursing facility level care, and only after you reach a financial threshold as well as a medical threshold for being in that nursing facility in the first place. I'm mentioning this to keep that in mind as you consider how much of your or your loved one's savings you are prepared to spend down, because in the end, an assisted living facility, if you have ultimately gone ahead and spent down your savings to the point where your monthly applied income, usually Social Security, perhaps Social Security coupled with a modest pension, perhaps depending on whether you've served in a branch of the military, you also have veterans benefits. If these are all enough to cover your monthly costs and or your savings can kick in to go ahead and to cover occasional or chronic a la carte costs, then you never have to worry about moving out of an assisted living facility unless you medically need a nursing facility instead. Most folks are going to reach a point where an assisted living facility may not be willing to go ahead and keep you if you've been drawing down on your savings. And then when you're only left with your monthly applied income, whatever form or forms that takes, to go ahead and to say, sure, you can stay for less. Because as you can imagine, in this economy, the price goes up, not down. So as a family, doing your research, being prepared, those weren't just bullet points for the sake of just getting the conversation started. Those are archetypal categories of let's contemplate scenarios like, what if I or my loved one runs out of their savings and is only earning what their monthly applied income provides them at that stage? And if it is not equal to the cost for that assisted living facility, what are we as a family prepared to do? And if we are not prepared or to go ahead and to supplement, then are we prepared to look to see whether or not a nursing facility model coupled with an application to Medicaid, assuming financial eligibility as well as medical eligibility exist, as our next best option? This is stressful stuff, and I'm grateful that you're either here with us live or you're watching or listening to this recording and reading the slides at your leisure at some point in the future, so that you can take a breath, understand that unless you're in an emergency situation, what we're talking about does require research, preparation, and getting advice from those agencies like the Area Agency on Aging, like the Aging and Disability Resource Center, and now, since we're talking about long-term care facilities, your long-term care ombudsman program, so that when you make a choice, you're making the best possible choice based on the facts on the ground as observed by these professionals. So let's talk about nursing facilities for a moment. There is a situation where when you need skilled services, say post-discharge from a hospital, you're in need of rehabilitation services, or you have a regimen prescribed for IV antibiotic therapy for several weeks, where you may end up in a nursing facility because that nursing facility also boasts the type of skilled services, rehabilitation, wound care, IV care, that you need for that period of time. In which case, Medicare will pay starting on day 1 and through day 20 at 100%, and then starting on day 21 through the maximum coverage date of day 100 at 80% of whatever you need for what is considered a short, not long, short-term stay that happens to be inside the walls of what is typically a long-term care facility. My advice, don't go there. I'd much rather see you working with case management in a hospital to discharge to a long-term acute care hospital, or LTAC for short. Or if rehabilitation is primary amongst your needs, to what is called an inpatient rehabilitation facility, or an IRF. These standalone facilities tend to have better staffing ratios. And ultimately, I want you to consider this. That staff is there to make sure in those LTACs and in those inpatient rehab facilities, those IRFs, that you get the 2 hours or more of physical rehabilitation, of occupational rehabilitation, of speech rehabilitation with the skilled therapists who are assigned to you. And by the way, I use that 2-hour number as a minimum in order to maintain your qualification for staying in that facility, that you are capable of doing at least 2 hours of that. That is a bare minimum. Most cases, we're talking about 3 hours per day. But be that as it may, what we're talking about here are facilities where it is in their best interest to make sure that you are awakened, that your activities of daily living, from getting you toileted to washed to dressed to fed, are done in a timely fashion so that you can partake of said therapies and they can continue to go ahead and charge your insurance or Medicare for said services. The skilled section of nursing facilities is designed to do the same thing. However, because the staff is there for the long-term care residents as well as for any short-term residents who are there to partake of therapies, IV antibiotics, etc. And because we know that nursing facility staffing is, well, terrible, you may be facing a situation where you are not awakened, toileted, washed, dressed, fed in time to get your therapy, which isn't just an inconvenience. It can have a huge long-term effect on your recovery. So my advice to you is dig in your heels with case management in hospitals and refuse a discharge until, assuming the option exists in your community, a bed is available in an LTAC, again, a long-term acute care hospital, or an IRF, again, an inpatient rehabilitation facility. If you're out of options, yes, go to a nursing facility if it's between that and being helpless at home. But as soon as you know where you are going, please, please, please contact the long-term care ombudsman program. They're the ones who are going to help you, with your consent, of course, to make sure that care planning and the implementation of said care planning is done in a timely fashion. And if there are any issues with staffing making you late or making it inconceivable that you can fulfill your therapy needs that day, that it is addressed as soon as possible. Your recovery is worth it. And having advocates may make that not just possible, but likely probable. Nursing facilities are expensive in terms of long-term care. They start at $7,500 a month and go up from there. So it's important to remember, we're talking now, I'm going to switch over to the long-term care side of nursing facilities, where it's important to recognize what that means in terms of your spending down of your savings if you don't yet financially qualify in order to receive Medicaid benefits, which, coupled with your monthly applied income, again, your Social Security, perhaps a modest pension, and so forth, is going to cover, minus a very modest personal needs allowance that you get to keep, your stay and your care holistically within that facility. We live in a country in which yes, you have to spend down all of your savings in order to go ahead and to eventually take advantage of what men do to help pay for your day-to-day cost in a long-term care facility like a nursing facility. Doesn't count in assisted living facilities, but in nursing facilities, that spend down with the goal of applying for Medicaid is very often what the facility will start talking with you about as they begin to see that your savings are winding down in the next few months, but they want to keep you, even if it's at a lower rate, like the negotiated Medicare daily rate versus the private pay rate that you will have been spending at that point. Nursing facilities, like assisted living facilities, will have memory care units. However, there are very few nationwide, very few nursing facilities that are standalone memory care only buildings. It's just not a viable financial model for the nursing facility industry. So 99% of the time, you're going to only have nursing facilities where if memory care is offered, it is offered in a secure unit that is part of the campus. One thing to keep in mind, by the way, when it comes to memory care in a nursing facility, memory care in an assisted living facility, is to make sure that these folks are ultimately certified. And what I mean by that is, in addition to being licensed facilities by the state, whether you're with us in Texas or in another state watching this live or the recording, there are certain requirements that each state has that are based on federal standards from the Centers for Medicare and Medicaid Services primarily, especially when it comes to nursing facilities, for how a licensed facility is to gain and maintain its licensure. If they also offer memory care, ultimately, that secure unit needs to be staffed by people who not only assist them with their activities of daily living, but they are specifically trained to work with people who are living with some form of dementia that is severe enough so that they are no longer safe to reside anyplace else, whether aging in place or in an independent living setting or in a non-memory care type of assisted living or nursing facility setting. We're talking about, at least on the assisted living side, $5,500 a month and more, depending on a person's needs. And it is likely going to be higher than that. Nursing facility side, you already saw that it starts at $7,500 a month and above. And again, if you're going to be paying that much, either out of pocket or ultimately after a spend down period so that you can successfully apply for Medicaid benefits in that nursing facility, you want to make sure that the people who are trained to work with memory care residents are continuing to further their education, which is one of the requirements of being a certified Alzheimer or dementia care unit or standalone facility that each state will award to people once they have met certain minimum requirements for said care. If they don't have that certification anywhere, but they claim that they are able to safely take care of your loved one in a memory care unit or a standalone facility, walk away. It's not worth it. I want to say one word about the personal care home model. Like I said earlier, in Texas, when you have a facility of any size or type that has 4 or more beds, it is now a licensed assisted living facility, according to Texas Health and Human Services, and subject to oversight through them and subject to the long-term care ombudsman visiting the facility in general and with consent advocating for resident rights and care when needed. We find, though, because the cost varies widely by the amenities that are available, again, it's just like living in different neighborhoods, different personal care homes. Some are very basic, some are very extravagant, most are someplace in between. If you decide that you want to go for a personal care home model because word of mouth or advertising has convinced you that the owner operator, and it is likely an owner operator, which is why I used that term, of 3 beds or less, is prepared to go ahead and to take exquisite care of you or your loved one in all of their activities of daily living, that assistance with, but also providing them with all of the amenities of home, transportation, etc. You get the list. Great. If you trust them, go for it. I will say that if the relationship sours for any reason, and you are in a non-licensed, as in 3 or less beds, personal care home, your protections are essentially the same as those that exist in, say, a landlord-tenant relationship. So it is a question of rights as someone who relies upon the owner-operator of a 3-bed or less personal care home versus having the oversight of various governmental agencies like Texas Health and Human Services, like the Long-Term Care Ombudsman Program in a 4-bed or higher model. So something to keep in mind, which is a good segue, by the way, for all the different things that we need to consider when it comes to facilities in general. You know most of these already. Evaluating your needs, talking to your friends, researching whether it's websites of facilities, online reviews, Medicare's nursing home compare. I wish that something similar existed for assisted living facilities. It does not. But there's no substitute for the last 3 bullet points. Visiting at least twice. Visit with an appointment, and since we are out of a pandemic period, visit without an appointment. If you are in a licensed facility of 4 beds or more, assisted living or nursing facility, they are required to have what is called their survey book available to you or any consumer to read upon request. The best places will have a sign saying, just ask us, or they'll leave the survey book out. And in reverse chronological order, you will find in that book not just routine surveys, but also the results of non-timely surveys and investigations, if any, in that facility. It's important to go when they are not expecting you so that you can see what they are like when they are not rehearsed. When you are there, whether you're there with an appointment, without an appointment, use all of your senses as you go through that facility, especially your sight and your smell. Sight as in, do the residents appear comfortable? Are they engaged in various activities when those activities are scheduled? Are there activities scheduled? There might be a calendar on the wall somewhere, or hopefully in multiple places throughout the facility for the ease of residents being able to check when activities are taking place. The smell part has to do not just with the nasty smells. It also has to do with, does the cooking smell good? Remember, we're talking about facilities where the core interdisciplinary team may be primarily clinical and social service based, but don't forget the cooks, don't forget the laundry, don't forget the housekeeping. These are folks where ultimately, if the place smells good, because the cooking smells good, the housekeeping is kept up with, laundry is fresh, sheets are changed, not just that people are washed. People can be washed regularly, and if they're back in dirty clothes and dirty sheets, wow, that's a major inconsistency. Those are things to keep in mind. I will go ahead and remind you that the turnover rate for long-term care facilities is high. So if you have done all of this, as well as the last bullet point, asking a long-term care ombudsman to get their impressions or to give their impressions of the facilities that you are considering, because remember, they're visiting there regularly as well as upon request when there are resident needs or questions. It may be that you say, yes, this place is great. And then 6 months later, there's been a turnover from top to bottom for various reasons. Go back to the unscheduled visits, this time as a loved one of a resident, and keep using all your senses, whether you're a resident or not. And if you don't like the sights and smells that you're seeing or experiencing, let the long-term care ombudsman know. Most facilities, when appropriately motivated, will do the right thing. But there needs to be an opportunity for you to go ahead and to see whether they're doing the right thing when they think no one is looking. If there are problems, Harris County's long-term care ombudsman program is listed here by way of the contact information for the managing local ombudsman, Greg Shelley. His phone number, his direct line, and his direct email are listed. But you may also decide to file a complaint with Texas Health and Human Services, their long-term care regulatory arm. And these are the ways you would do so: by phone or by email. If you find that you're not in a licensed facility, say it's one of those personal care home models, you're going to need to rely on the Texas Department of Family and Protective Services, what we know colloquially as Adult Protective Services, or APS, by consulting their abuse hotline, again by phone, or through their website. There is an electronic submission process. I encourage you to do all of the above, depending on the situation you find yourself in. But regardless of which agency or agencies you determine to be appropriate to contact, I left a bullet point in here to remind you that once you've contacted those agencies, you need to take whatever intake information you've received, whether it's the name of the ombudsman who's going to be assisting with consent, whether it's the intake number through Health and Human Services or Adult Protective Services, and give that information over to your local, and here I'm going to recommend state elected officials, although the website that's on this slide has a listing for federal elected officials as well. And if you have a special relationship with a federal elected official, obviously a senator is going to cover the entire state, but if you have, say, a member of the U.S. House of Representatives in the area where that long-term care facility is located, who you have a relationship with, great, reach out to them. Otherwise, find the state officials, state senator, state representative who represents the district where that facility is located, and ask them to conduct what is called a legislative inquiry. You're giving them the intake number that you've received, or the name and contact information of the long-term care ombudsman with whom you or your loved one may be working, and you're going ahead and saying to them ultimately, we want you the odds are it's going to be the staff, not just the elected official, or perhaps the staff in place of the elected official, to go ahead and to contact these agencies and bump up the priority level. Now, you can provide all of the above, not just your contact information, the relationship to the person, if it's not you who's dealing with the possible abuse, neglect, or exploitation that triggers these, the name of the person who it may be involved, and not just the name, address, and phone number of the provider. But you're going to want to be as detailed as possible about what happened, the narrative of the incident, when it happened, where it happened, how that person was affected. If there are witnesses or anyone with relevant information, who they are and how to reach out to them, and whether it's official or unofficial audio and video records, providing those whenever you have them. Official audio and video records usually are in the form of the type of camera surveillance that residents have a right to have in their rooms, so long as they have provided informed consent, or if they can't make decisions for themselves, their proxies have gone ahead and made arrangements with the facility to sign off on paperwork that ensures that what will be captured only captures the direct experience of the resident involved. This is not to say, though, that such recording is foolproof. Remember, in nursing facilities in particular, because we're talking usually about shared living environments, there are these things called privacy curtains. And your camera may capture the audio of what's happening behind a privacy curtain, but it won't capture by video what's happening, which is why I do recommend that you have, in whatever form you choose, some type of unofficial recording device within the perimeter of the privacy curtain. Because the worst thing that can happen, if it is discovered, is that the facility has the right to go ahead and ask that it be removed. And that's it. It is not going to affect whether that you or your loved one can stay in that facility. It is simply the facility's right to say, if it is not registered with us, remove it from the facility. I will tell you, as a former long-term care ombudsman, not just a current community aging specialist, it has been the unofficial recordings that have helped residents far more than the official recordings. But I still would encourage both. Now, we're going to leave you with some selected resources, some of which is just background information about having the aging in place versus contingency plan conversation with loved ones, whether you are the person in need or your loved one is the person in need. And I wanted to make sure, beyond the long-term care ombudsman program, that you had the contact information for Harris County's Area Agency on Aging and for its Aging and Disability Resource Center. There's also a listing here for what is called the National Consumer Voice, which is the primary arm under which long-term care ombudsman and anyone concerned about resident quality of care and resident rights can seek out resources and current information about the state of long-term care. I highly recommend that you sign up for their communications, not just consult the services and resources that they provide. And on that website, in case you don't live in Harris County, you can go to the bottom of that page and you'll see there a link for locate your long-term care ombudsman. So again, in any county or territory, wherever it is that you call home, you can go ahead and you can make sure to be connected with the right person. Now, if that's too difficult, no problem. Just contact Greg Shelley and he will let you know where your counterpart in the county or territory where you live, where their program may be found, or to go ahead and to wrap things up, contact me, because I will be able to help you figure that out as well. Peggy and I are here for individual consultation, for reinforcement of anything that you have studied with us so far or will be studying in the future. And if you need additional information, or if you need assistance accessing, for example, the bottom part of the homepage for the National Consumer Voice and a walkthrough on how to locate your local ombudsman program, your local area agency on aging, aging and disability resource center, we will absolutely help you with that as well. And also give you some advice on how to further your research and, if necessary, discuss not just initial but ongoing care plans and implementation of care plans in long-term care facilities. So with that, I'm going to stop sharing and I'm going to go ahead and see. Yes. Yes, for the DFW area, all you need to do is just go ahead, Kristen, and go to the National Consumer Voice, go to the very bottom of that homepage, click on the link where it says locate your long-term care ombudsman, and Senior Source, by the way, is the name of the program that includes long-term care ombudsman in the Dallas-Fort Worth area. Although, again, the Dallas-Fort Worth area represents multiple counties, so you're going to want to double check and make sure that they're covering your county, which is to say the county in which your facility is located, the one you have questions about. Well, folks, thank you so much for sticking with us. And I know this is a lot of information. And next week, the paying for aging section is going to be just as dense. But I hope that when you get the recordings, when you get the slides, you're able to go back, refresh your memories of what you've heard in each of these sessions. And as I said before, if you have any questions at all, please reach out to us. Again, we can always be reached just by going through our website, hhci.org. I hope everybody has a kind and gentle week. And hey, stay cool and dry out there. Take care, everyone.